surgical director at our Comprehensive Stroke Center, professor of neurosurgery and radiology, and the associate residency program director for neurosurgery. And he's led many initiatives over the past several decades here, and I'm thrilled to have him join us for our CAB conferences. Welcome.
Thanks so much for having me, Jessica, and thank you for the opportunity to talk today about primarily about normal pressure hydrocephalus, the E-shunt or endovascular shunt, and what the STRIDE trial, which is it's going to be a randomized controlled trial comparing this new technique and approach to treat this disease versus the classic open surgical approach. These are my disclosures. So I work very closely with a lot of new device companies, and none of which are relevant to the topic today. So normal pressure hydrocephalus is a condition where there's abnormal buildup of cerebrospinal fluid in the brain. It typically affects the elderly, generally people over 60 years old, and it's often misdiagnosed with other diseases, neurologic diseases of the elderly, like Alzheimer's or Parkinson's, or even more commonly is just mistaken for normal aging. The unfortunate truth is the majority of these patients with normal pressure hydrocephalus in the United States are untreated. And it carries quite a high morbidity mortality, with a 5-year mortality rate upwards of 88%, which is similar to that of cancers. So again, there's increased cerebrospinal fluid in the brain, and it's termed normal pressure because despite the increase in fluid in the brain, their pressure, as measured by a spinal tap, is often in the normal range. Why is this condition happening? In the pathophysiology is not really well understood, but likely is multifactorial, and there's probably different ways in which patients can develop this condition, leading to a similar clinical presentation, whether it's chronic hypoperfusion, some kind of lymphatic impairment, metabolic disturbances, gliotic loss of the brain tissue, impaired spinal fluid reabsorption, or blood-brain barrier disruption. When we look at normal pressure hydrocephalus by the numbers, studies suggest that the incidence can range anywhere from 1 to 5 in 100,000, that the mean age of presentation is about 70 years old, and there's a somewhat equal sex distribution. According to the Medicare population, the overall prevalence in 2008 was 0.2%. Most patients' age range at presentation are between 65 and 79. And as mentioned previously, it comes with an extremely high mortality rate without treatment. It's estimated that there are over 700,000 Americans with normal pressure hydrocephalus, and again, less than 20% are getting the appropriate diagnosis and management. And so when it comes to clinical presentations, I often get a little nervous when I'm talking to a group of neurologists, because you folks are usually much better than me in making diagnoses, and I'm more of the doer. But as I'm sure you all know, that the NPH comes with the classic triad of gait impairment, cognitive impairment, and urinary incontinence. So the way I tell my patients, apologize for the misspelling there, but it's the 3 Bs. They have balance problems, brain problems, and bladder problems. The balance problems are usually often seen as slow, small shuffling steps, and it's usually the easiest symptom to spot and often the first one that appears. The brain is usually memory impairment, and The bladder issues are usually overflow incontinence. And so here is kind of a classic video of a patient who's pretty far along with normal pressure hydrocephalus. And you can see the kind of shuffling gait, hunched over, difficulty transitioning from sitting to standing, and balance issues, gait initiation failure. And you can see the same patient now after a surgical placement of a VP shunt. Clearly, the balance is improved. And then what you tend to notice over longer periods of time is that the improvement in walking and balance actually gets better over time. So for the cognitive issues, which is, again, the second most common set of symptoms, and as far as NPH patients are concerned, you need at least 2 out of 3 of this triad to really be considered normal pressure hydrocephalus. They tend to have executive dysfunction with slow processing and problem solving, impairments in attention, and executive function are typically more severe than those with Alzheimer's. As far as memory, they have memory deficits with poor retrieval, with intact recognition. And that tends to be of a similar deficiency in Alzheimer's. What they do not get are aphasias, agnosias, apraxias. They can have depression because, of course, this is the quality of life. Patients suffering with this condition is quite bad. And a lot of these patients can be referred to dementia clinics because a lot of these symptoms can be overlapping with concomitant types of dementia. As far as urinary symptoms, it tends to occur later in the disease. Urgency and frequency are the most common types of urinary symptoms. Incontinence can occur, but it's not defining nor necessary. And if it does occur, it's usually overflow incontinence thought to be caused by detrusor overactivity or hyperactivity. A lot of the urinary issues are intrinsically tied into the gait issues because if they have a hard time walking, then they have a hard time getting to the bathroom on time. And so how are we making the diagnosis? Well, they're going to have at least 2 out of 3 of these triad of symptoms. And of course, they need to have hydrocephalus, communicating hydrocephalus on brain imaging. And the way that we tend to define it is by using the Evans index. And the Evans index is a ratio measuring the lateral ventricles, the max width of the lateral ventricles, the frontal horns of the lateral ventricles to the max diameter of the brain in the same slice. And that index greater than 0.3 is confirmation of ventricular enlargement. Another way to diagnose it on imaging is looking at the callosal angle on a coronal scan. And it tends to be between 40 and 90 degrees for normal pressure hydrocephalus patients. And it has to be communicating. So all the ventricle system should be enlarged. If it's not, then it's a different kind of hydrocephalus problem, namely obstructive hydrocephalus, and therefore would be thinking about different treatment modalities and different issues. There are other forms of communicating hydrocephalus. The other most common being congenital ones, and we see it in the pediatric populations. There are other conditions, namely the one most commonly that I see are patients with subarachnoid hemorrhage who can develop communicating hydrocephalus as a result of that bleeding. In its more severe state, and when you have high pressure hydrocephalus, the symptoms become quite a bit different, and they often have headaches, vomiting, coma, neurologic dysfunction, and death. And that's not something we tend to see with normal pressure hydrocephalus. So when it comes to this trial and how we are assessing patients for normal pressure hydrocephalus and assessing their outcomes, we are doing specific gait assessments called the timed up and go test or tug test. And this is a test where they are sitting in a chair, get up, stand up, walk 3 meters, turn around, walk back, and sit back down. And this is then recorded and measured as far as time. The cognitive evaluation that we are doing is the MoCA, but there are lots of different ones available. And for the study, they've picked some, and there are a number of different urinary surveys that you can do, but they have picked this OABQ one to assess urinary dysfunction. And so the other big part of deciding which patients would benefit from a treatment, namely surgery or endovascular shunt, is a response to CSF drain trial. And that can be done either from a single lumbar puncture, high volume tap, or a lumbar drain trial. And it has been shown that, as far as the sensitivity and specificity of these two different trial testings, that lumbar drain trials tend to be more sensitive and specific compared to the high volume taps. I will say, though, as far as convenience, that and in my practice, I tend to lean towards doing a single high volume tap to start, because I've had pretty good results in seeing predictive results in seeing patients who improve and then go on showing benefit from definitive therapies. The problem with lumbar drain trials is they have to be hospitalized and for a few days, and that can come with a bunch of headaches given the patient population that we're dealing with. And admitting elderly patients to the hospital can be pretty disorienting, and I find it often confuses the issue. So the standard of care for patients who have diagnosed normal pressure hydrocephalus is cerebrospinal fluid diversion via ventriculoperitoneal shunting. And it has been shown to be highly effective in improving the clinical symptoms of normal pressure hydrocephalus. And it's been evaluated as far as cost effectiveness, and it's shown to that it can save years of life, up to 2.2, compared with natural history, and improve quality of life in these patients. However, the response tends to vary as far as how much improvement in patients who get shunted, anywhere between 30 to 90%, looking at different case series. And the effectiveness of this treatment really depends on correct diagnosis and management, in addition to minimizing shunt-related complications, because doing any kind of open surgical procedure in the elderly comes with a fair amount of risk. Predictors of poor outcome after surgery tend to be, again, whatever other comorbidities the patients may have, elevated age, and severe dementia on presentation. So when it comes to the current treatment, standard of care, while it does work, when it does work, it can work well, there are real and serious risks. The five most common types of complications that we see in surgery or obstruction of the tubing system, or occlusion of it that requires a revision surgery, which can then lead to a resumption of the previous symptoms that they had when they were first presenting. They can have a ventricular catheter misplacement, and this can be, again, a range of different problems that can come from this. Either, again, the shunt not malfunctioning and not working properly, or the catheter actually causing neurologic impairment or damage to brain structures because of where it is and that it wasn't meant to be there. Probably the most common problem that I see in normal pressure hydrocephalus patients getting shunts are over drainage, meaning that it can be very hard to find the exact right amount of cerebrospinal fluid to drain. And over drainage can be quite serious, leading to the formation of subdural hematomas and leading the need to have to either turn the shunt off if it's a programmable shunt, or remove the shunt, or even need surgeries to evacuate subdural hematomas in severe cases. Infection, while it's uncommon, it can be extremely life-threatening condition, can lead to meningitis and lead to very, very poor outcomes. And any other kind of mechanical failure of the shunt on the distal end, which could lead the need for additional revision surgeries. So now we're going to kind of transition to what the new device is, the new technique, which hopefully will impress you all. So the company that makes the endovascular shunt, or E-shunt, is Ceravasc, and it's an investigational device. And Montefiore was a site in the pilot study, the first in man US study, which just completed. And we're moving on to now the FDA pivotal trial, IDE pivotal trial, which is the trial that will get FDA approval and as an indication for normal pressure hydrocephalus. And before I talk about the trial, I'm going to go a little bit more detail about the device itself. So this is what, on the right side, this is what the E-shunt implant looks like. It's a minimally invasive endovascular device, and it's designed to mimic the natural arachnoid granulation system of CSF absorption. And on the distal end of it is a subarachnoid space anchor, or Malacot, which measures 3 by 3.5 millimeters. And this is then connected to the shunt body, which is a silastic tubing system that is similar to a shunt catheter. And then on the proximal end, there is a slit valve, which it regulates a maximum of 10 cc's per hour of CSS flow at about 5 millimeter mercury pressure differential. The valve prevents retrograde venous blood flow, so there is never any concern of, if there is valsalva or pressure changes, that blood would spill back into the subarachnoid space. This design is very similar to what we used to do surgically, and still do surgically sometimes, called a ventriculoatrial shunt. And often that's kind of reserved for patients that have failed traditional ventriculoperitoneal shunts. So I think hopefully I turned the sound on, but if there's any issues, let me know. This is going to be a video just showing kind of how this procedure is done.
Percutaneous venous access is first established in the femoral vein using standard access tools. A guide catheter, microcatheter, and guide wire are advanced through the venous vasculature and through the internal jugular vein to gain access to the inferior petrosal sinus, or IPS. Once the microcatheter is in place, The guide wire is exchanged for the E-shunt anchor. The anchor is advanced through the microcatheter and deployed in the distal IPS or cavernous sinus distal to the target implantation site. The microcatheter is then removed from the patient, leaving the flat rail extending through the vasculature into the femoral venous access point. The anchor is a temporary delivery component that will be removed by the microcatheter after E-shunt implant deployment. The E-shunt delivery catheter is configured to receive the flat rail within a dedicated rapid exchange lumen and is advanced over the flat rail through the vasculature and into the IPS. Once the delivery catheter reaches the target implantation site within the IPS, needle positioning and orientation is confirmed with imaging. A beveled RO marker is present on the needle guard and is aligned with the needle bevel prior to needle guard retraction. This enables visualization of needle orientation under fluoroscopic guidance. An RO marker is also present on the delivery catheter shaft, proximal to the needle. The needle guard is retracted to expose the needle using a knob on the delivery catheter handle. When the two RO markers converge, the needle guard is fully retracted and the needle is exposed. The delivery catheter is then advanced across the dura to access the cerebellopontine angle cistern or CPA cistern. The implant Malacot is deployed into the CPA cistern from within the delivery catheter needle. The delivery catheter is withdrawn to deploy the remainder of the implant into the IPS and internal jugular vein and then removed from the patient. Once the implant is in place, the microcatheter is reinserted over the flat rail and advanced into the IPS beyond the deployed implant. The anchor is recaptured into the microcatheter and removed from the patient to complete the procedure.
So that's just a quick, sometimes, pictures are worth 1,000 words as far as understanding what exactly we're doing here. And so we've been doing these procedures in the United States for the last 8 months or so. And there have been, before the United States, there were two first-in-man trials in Argentina. And so far, since May, since the beginning of 2024, there have been 74 people who've had this procedure performed for different indications, including 15 for subarachnoid hemorrhage, 1 for idiopathic intracranial hypertension, and 57 for normal pressure hydrocephalus. Here below are a list of some of the sites in the United States that were part of the pilot study, of which Montefiore was one. I enrolled 2 patients in that study, and I actually was the first person in the United States to put in an E-shunt for a patient with subarachnoid hemorrhage as part of a compassionate use exemption. And I'll show those cases in just a bit. Just to kind of review here, the pilot study and how we assessed and worked these patients up involved, of course, screening, getting consent, doing the initial diagnostic evaluation, and regardless if they came from a neurologist with a full evaluation, we had to kind of redo everything ourselves. And so everyone got at least a lumbar puncture trial with a timed up and go test, MOCAs, and bladder surveys, including special imaging screening. And I'm going to talk a little bit more about screening because anatomic screening is a really, really important part of deciding whether a patient is going to be good for E-shunt. Once we have all of this information, and if they showed at least a 20% improvement on the tug test, and they got their anatomic screening, which was reviewed by an independent reviewing party, and they were cleared for E-shunt, then we would proceed with the procedure. Many patients get cleared only for one side of the sinus for anatomic screening, and so that part can be a little tricky, and that's where we have the majority of screen failures is for anatomic screening. Our assessments were done at 30 days, 90 days, 180 days, and then 1 year. And we are still in the kind of follow-up phase for our pilot study patients. What do we know so far? We know for NPH, we've had 59 patients treated, 49 of which have 90-day follow-up, 34 180 days, and 18 1-year follow-up. And what have we seen so far is that 77% of the patients have an improvement in their TUG scores, 68% had an improvement in MoCA, and 62% had improvement in bladder survey. And that's at 180 days. And it seems, and and again, we don't have the numbers for the longer term as much, but it seems like the treatment is effective over time too, with a slight kind of decrease in the bladder. And interestingly, again, we don't have enough patients, but a mild improvement in MoCA and maybe around the same for TUG. So what can go wrong? And of course, this phase 1 study was primarily a safety study. And so what are the risks of doing this procedure? And so the serious adverse events were as such. There was one sigmoid sinus thrombosis, and that patient was put on oral anticoagulation with improvement of the symptoms in 2 days. There can access site complications from doing endovascular procedures, which is not uncommon. Pseudoaneurysms, and those things are usually easily managed with non-invasive therapies. The most interesting adverse event that people have seen in this device is a transient cranial nerve 6 palsies. And so that was something unexpected. But I'm going to show a little bit about what they've learned from and these were primarily in the kind of the really early patients, and what the early operators have learned about this procedure to help avoid having this issue. There have been 2 cases of asymptomatic thrombosis, one ongoing and one resolved, and one UTI. So when we think about this and we compare it, to surgery, it's actually pretty low compared to surgery, what we know of surgery. But again, dealing with this cranial nerve 6 thing, of course, cranial nerve 6 runs through the cavernous sinus, and it runs right under a Gruber's ligament, and so what most people think is going on is that the stent anchor, and where you put that stent anchor, either in the kind of lateral aspect of the cavernous sinus versus the horizontal aspect, that if that stent anchor is going up and it's a pretty beefy stent with pretty high radial force, that if you unsheath it in that area around where the 6th nerve is running through Gruber's ligament, because it's a kind of a tethered area, that it can kind of compress on the 6th nerve, which can cause transient palsy. And learning and understanding this has helped to be able to avoid having this complication in more recent patients. I will say that in the 3 patients that I treated, we had 0 cranial nerve 6 palsies. So thankfully, I did not encounter this complication personally. When it comes to procedure planning, there are pretty specific imaging testing we need. We need thin slice CAT scans that look at the bony anatomy and specifically the bony overhang. the petrous bone, which can sometimes prevent the bevel needle from accessing the CP angle cistern. We are looking at the distance, the space of the suppleness of the CP angle cistern itself, and to making sure that the critical neural structures are far away from the inferior petrosal sinus. And most importantly is proximity to important arterial anatomy. So it has to be far away from any looping vertebral pica or ICA branches to make sure that it's safe to stick a needle into the cistern. And you need to have all of these things. And so because there's a lot of strict criteria, and it's overly strict because this is a new device seeking FDA approval, and they want to be extra careful to not have any sort of bleeding or neurologic complications, that many patients wind up screen failing when it comes to anatomic screening. So here are some just pictures in the angio suite on the top left of kind of what the bevel needle looks like, and the stent anchor. On the bottom left, you can see a CAT scan after where the E-shunt is sitting in the CP angle cistern, and how it exits again through the inferior petrosal sinus into the jugular vein. This is one of the early patients showing a 30-day follow-up on MRI imaging. And if you do it with contrast, sometimes you can actually see, gadolinium exiting from the E-shunt into the jugular vein, which is a good sign that the E-shunt is working as far as assessing function. On the left, you can see pre-TAP test and then 90 days after on the right. So let's see if we can get these both going at the same time here. So you can see that they have the similar kind of improvement in gait that we would expect to see from shunt surgery. And so now we are at the point of the trial, the STRIDE trial, which is we are Site 4 and we are active. So if you have any potential normal pressure hydrocephalus patients who are interested, please do send them my way. And so what is this trial going to be? It's a head-to-head trial comparing E-shunt to VP shunt. And it's going to be the largest randomized controlled trial in normal pressure hydrocephalus ever, evaluating this new minimally invasive system and comparing it to open surgery. The primary efficacy endpoint in STRIDE is improvement in gait impairment at 6 months compared to baseline. And the primary safety endpoint is a comparison of the total number of adverse events observed within the first 6 months following treatment. So who are the patients? We're looking for patients over 60 years old. They need to have a history or evidence of gait impairment for at least 3 months, and at least 2 out of the 3 classic triad symptoms of normal pressure hydrocephalus. Whereas they need to have the imaging findings as well. They need to be agreeable, either them or their caregiver is able and willing to provide consent and able to kind of show up to all the necessary follow-ups. They'll need to have the additional testing that we are going to do, which is, again, the trial testing with either lumbar tap or lumbar drain, and showing improvement with that. They'll need to have the screening, MRI, and CT scans, and be independently adjudicated that they are amenable for E-shunt. And the commitment is a 1-night overnight stay for patients who get randomized to E-shunt system, and agree to follow up at least 1 year. So again, already kind of discussed, but primary effectiveness, the primary endpoint is going to be improved in tug test at 6 months. As far as adverse events, what are we kind of looking at for adverse events? Post-op infection, evidence of overdrainage, symptom either by symptoms and or CT scans, or any kind of hemorrhage, symptomatic or radiologic. So as far as our sample size, it's going to be 1-to-1 randomization. And we have no controller say how they get randomized. So patients have to be willing to and agreeable in understanding that. Our sample size will be 230 patients, 115 in each group. And there's going to be somewhere between 20 and 30 sites in the United States and outside, of which we are one and we are active. As far as kind of how does this work, there's a lot of course, screening assessments that have to be done by our research team. Whether or not you've already done some of these, it doesn't really matter. So the earlier you find potential patients, we're happy to kind of do the workup for any patients that may be interested. So just send them my way. And if they screen out and then they will leave the study and not be part of the randomized controlled trial, it doesn't mean that we won't do anything as far as if they are an anatomic screen failure, they may not be able to participate in the study, but it doesn't mean they can't get the traditional surgical treatment and still get help for their normal pressure hydrocephalus. So as far as specific inclusion criteria, over 60, willing to participate, gait impairment more than 3 months, classical clinical symptoms, some kind of brain imaging that shows ventricular enlargement disproportionate to atrophy, and therefore and has to be communicating. They need to show at least a 20% improvement in the tug test after a tap test or lumbar drain test. The opening pressure has to be at least 8 or higher. And that's one thing that we've noticed from the pilot study is that if the patients have low pressure hydrocephalus, that they don't seem to benefit from any kind of CSF drainage and are probably not good candidates. They need to have also a baseline cognitive evaluation assessed by MoCA of at least 12 or higher. So they can't have advanced dementia because it's not good. This is not the patient population we're looking for. So what are the exclusion criteria? They have to be able to walk at least 10 meters so they can participate in the tug test. And it can be with or without an assistive device. That's okay if they need an assistive device, but they have to be able to do that. If they have obstructive hydrocephalus, that is a contraindication. If they have an active infection, either systemic or in the cerebrospinal fluid, we will be sending their cerebrospinal fluid when we do the tap tests. That's an exclusion criteria. They can have been treated before. So if they had an ETV or any kind of E-shunt, they would not be a candidate. If they have any kind of hypersensitivity or contraindication to heparin or contrast agents, which they cannot be adequately pre-medicated or desensitized, then that's an exclusion criteria. The big thing that you're not usually probably thinking of is whether they have some kind of elevated jugular venous pressure, whether it's from right heart failure, jugular vein stenosis, cirrhotic liver, AV fistulas in the arm for kidney disease, brain AVMs, anything that might impact the venous pressure in the jugular vein, that's an exclusion criteria. I think for obvious reasons, because you don't want to have high pressures in the place where you're diverting cerebrospinal fluid to. They cannot have any coagulopathies at the time. They have another important one is they can't have had a stroke within 180 days. They have to have normal blood values. They can't have evidence of any sort of DVTs. Again, because we're working inside the veins, we don't want that to somehow clot off our E-shunt. They have to have a life expectancy of at least a year. They can't be participating in other trials, and they can't have an established neurodegenerative diagnosis, whether it's Parkinson's, Alzheimer's, or Lewy body dementia. Any major psychiatric illness other than depression is also exclusion criteria. If they need an intracranial neurosurgical procedure within 90 days, then that's an exclusion criteria. If they have an MRS of 0, meaning that they don't have any symptoms, then they can't be included. Or if they're severely disabled or dead, obviously we don't want those patients either. But anywhere from 1 to 4 is okay. MRS. I'm going to show my patients. So my first patient was this compassionate use patient, is a 40-year-old Hunt grade 4 subarachnoid hemorrhage that had also an associated intracerebral hemorrhage in the dominant hemisphere, which caused her major disability, aphasia, and right-sided hemiplegia. And she was able to get coiled and then surgical evacuation with definitive aneurysm clipping at that time, and had very poor neurologic state. Her EVD was eventually weaned, and I think she was at that point 4 weeks into her hospitalization when she developed a right-sided DVT on the floor, and they decided to do a surveillance head CT while she was on the floor to decide on whether it was okay to start anticoagulation for the DVT. As it turned out, she had communicating hydrocephalus. She was worked up for it. Her opening pressure was normal. And so we're kind of stuck between a rock and a hard place where we'd have to put in an IVC filter, but she was pretty debilitated with her hemiparesis, and it thought that putting in a filter in a patient like this usually doesn't end well with further progression of venous thrombosis. And so we thought, well, maybe we can do E-shunt and then start AC because it's minimally invasive. And so we got compassionate use from the FDA and got the anatomic clearances, did a lumbar TAT trial and showed that she was more awake after trial and got okay to proceed. This is kind of the venous anatomy that we're looking at when we're doing these procedures. And so you can see the cavernous sinuses, both inferior petrosal sinus and the right jugular vein, which is the side in which we're going to be placing the shunt. On the right is the unsubtracted view, just showing kind of the bone. And to the left there, you can see where the clip in the coil was of the aneurysm. So the first step is again unsheathing the anchor. And so this is something we learn. If you unsheath the anchor in the horizontal portion of the cavernous sinus, you're much less likely to get a sixth nerve palsy. You can see, and what we think is, that you can, in some cases, see actually where the sixth nerve is along the lateral aspect of the cavernous sinus, because you do not see a contrast in a small hole where the nerve exists. So the next step is, once you have the anchor out, is to retract the needle. And you see then this is the needle now sitting in the inferior petrosal sinus. And then you pull the needle back to the point where the trajectory will push it straight out into the CP angle cistern. And you can kind of see that it's pretty stiff. So you need a lot of support. We're using a quadraxial system from the leg and kind of pushing this needle into the CP angle cistern. So this is pretty scary to do because it's something we've never done before. And, sticking needles into veins, into subarachnoid space kind of sounds a little scary, but, the important thing is that there's very, very detailed anatomic review being performed to make sure that this is a safe thing to do. And often what happens is because of the trajectory, it limits the ability of this needle to skive or go anywhere dangerous. It will just run right along the anterior skull base, and there's really nothing else there. So it's pretty safe. And then on the right here, you can see the needle bevel going through the inferior pituitary sinus right there. And so you want to see the whole part of the needle out. And that means that the needle is completely through the inferior pituitary sinus and sitting in the subarachnoid space. Once you're there, that's when we're introducing the E-shunt. And what we're going to see is this malachite coming through. So that's the E-shunts going to the CP angle. And then now we're unsheathing everything to let the E-shunt kind of sit. And this is to the right is kind of the picture of what we're seeing right there. So this is again an unsubtracted view, kind of all the markers that we're seeing. You know, again, the stent anchor is in the cavernous sinus. Our E-shunt malachite is sitting in the CP angle cistern, and this is where we kind of unsheath. We're unsheathing the proximal part of the stent. And this is how it looks on CAT scan afterwards, exactly as intended. And this is her MRI at 2 weeks follow-up, actually showing a decrease in the size of her ventricles, which was encouraging. So I'm going to go now to the 2 patients that were actually in our pilot trial. So these are now MPH patients. The first one was a 67-year-old, 5 years of progressive gait instability, mildly elevated, but still within normal opening pressure. Pre-tap MoCA was 23 out of 30 and TUG was 20, and post-tap showed a 5-second improvement. And on the right there, this is the initial walking. So he didn't look so bad, actually, as far as, you know, it was definitely not a high-level MPH patient, I would say, as far as like progression. This is the evaluation. So we're looking at both inferior petrosal sinuses, the size of the CP angle cistern, and then the proximity of the vertebral arteries here to the exit points. And so you can see that the right vertebral artery is actually coming dangerously close to the inferior petrosal spine. And this patient was only cleared for the left side and not the right side. So here is our venogram of the cavernous sinus showing cavernous sinus and both inferior petrosal sinuses. This is kind of showing again puncturing through the inferior petrosal sinus. The E-shunt placement, exactly where we want it to be. And pre-treatment on the left, post-treatment on the right at 30 days, showing a decrease in the ventricular size, an improvement in his MoCA and TUG, and he feels great. He's really, really happy about getting this procedure done and is extremely grateful. For those that don't believe, this is the MoCAs that he did before and after. Interestingly, on the right there, you see that he where he actually lost points was not putting numbers on the clock. And I don't know if that's a step up or step down, because maybe, you know, he got so much better you didn't need the numbers to figure out what time to put in. And here's the pre and post tugs. He was already pretty good to start, but he was even better afterwards. Our second case was a 74-year-old PhD He had a lot more stuff going on. He had some kidney disease, stents, way back. He had a stroke a few years back. He had progressive gait instability, shuffling gait, imbalance, memory. He was more of a classic NPH patient. He also had a fall that led to a clavicle fracture, and the falls are really what's, again, associated with a lot of the morbidity in these patients and mortality. So he had a LP opening pressure 14, 42 cc's removed. His tug again showed about a 5-second improvement. He also had improvement in MoCA as well after the tap. On his anatomic screening, he was cleared for a right side, and you can see on the right side, and it's something you don't see so well on MRI scans, and something we're learning about is that the inferior petrosal sinus and the anatomy of it can be highly variable, and there can be multiple channels. And even though it looks like a solid structure, say on an MRI, and that can lead to challenges in being able to deliver the device when it's of a small diameter, because you need a certain size to be able to get your system up. Nonetheless, we were able to do it even in a very small inferior petrosal sinus. And so here our stent anchor is again sitting in the horizontal cavernous sinus. And what you can see here on this AP is like this hole right there, this is where the sixth nerve is coming through. And these are things that we're just really learning about and figuring out now, because before this, we haven't been doing venography of the cavernous sinus on a regular basis and really taking the time to understand it and the clinical implications it might have. So he had his E-shunt put in, and he again got better too on gait. He decided to use his assistive device on the 90-day follow-up. I mean, no, sorry, not on the 90-day, on the 30-day, but so we used the 90-day, but you can see that he certainly had an improvement in his speed and balance before and after. And objectively on MoCA, he had better scores, but according to his wife, he is still having some subjective memory issues. And again, it's not like, again, for these NPH patients, it's not always, they're back to like they were 40 years old. They may get some improvement, but not 100% improvement. So the E-shunt is just one aspect in which endovascular neurointerventional is kind of paving the way for minimally invasive approaches and treatments to neurologic diseases. And I like to think of it in kind of how cardiology and interventional cardiology has developed over time. If you look at cardiology, they had, you have your MI and you have your interventional cardiologist, but now they also have structural intervention. They're doing valve replacements and things like that, and electrophysiology, which is doing, all those other things. And so when it comes to neuro, we are still in the like MI phase where we're doing strokes, we're doing aneurysms, and we're just kind of engaging in some of these other therapies, with E-shunt being one, as well as many more things to come because of brain-computer interface development. We're going to probably have a whole field of functional neuroendovascular that can deal with restorative neuroendovascular, which is where the first device is looking. But I think that's again, there's way more to come for that, whether it's psychology, pain, epilepsy, cognitive improvement, the ability to stimulate parts of the brain from a transvenous electrode is a real thing, and it's going to kind of change the way we think about treatments of the brain. Other areas is neuroendovascular oncology, which is again a new field that is just blossoming right now. Now, again, the idea of sticking a needle through someone's inferior petrosal sinus right next to their brainstem is a scary endeavor, and it requires some courage to be able to pioneer this new technology. And at least in the initial experience, I'll say that, it is extremely safe and likely safer than open surgery because it's a minimally invasive approach. And that's something we've seen in other neurointerventional treatments. When I started in neurosurgery, most of brain aneurysms were treated with open surgical clipping. And at this point, with the advancement of minimally invasive neurointerventional techniques, only 5% of all aneurysm patients in Montefiore get open surgery, and a great majority are now treated minimally invasively. And I see the same thing happening kind of around the neurologic market when it comes to brain disease and brain disease treatment. So in summary, E-shunt is an exciting new technology. It's going to change the way we treat various forms of communicating hydrocephalus and not just NPH. However, the first FDA on-label indication will be for NPH. We are an active site and available for evaluation of NPH patients in and outside of the STRIDE trial. The STRIDE trial is just one of 15 ongoing clinical trials for neurovascular patients that I run as part of our research team. I'm the national PI on a minimally invasive aneurysm device that's coming to market called the Galaxy device. We run trials for middle meningeal artery embolization for subdural hematomas. We run trials for strokes. We run trials for migraines, the endovascular treatment of migraines. And so there's really a lot of stuff going on that happy to collaborate with anyone from the neurology group, depending on your area of interest. I will say, and shout out to Synchron and the Command trial. For those that don't Synchron, they're kind of in this Elon Musk type business where they develop a stent electrode that they're designed to put in the superior sagittal sinus for patients with ALS to help severely disabled ALS patients be able to communicate with their thoughts to help improve quality of life. And this trial was likely going to be opening in the second quarter of this year, of which we will most likely be a site. So if any of you have any ALS patients or engagement in that patient population, stay tuned because we'll hopefully be able to offer something for those patients as well. Beneath that, this is my contact, my website. If any of you do social, Instagram, X, my cell phone is probably the easiest way to reach out to me. And yes, QR code is all my contact information if you want it. So thank you very much for the opportunity. And I'm happy to stop now and answer any questions anyone may have.
Thank you, Dr. Asha, for the broad overview of the minimally invasive approach. I know that Dr. Cohen had a couple of questions. I'm not sure if he can unmute himself. Let me just make sure he's still on. Okay, Go ahead, Dr. Cohen.
Hi. So first, thank you for that. That was great. Definitely, there's a very wide range of potential places that this technology can go to. So looking forward to where this goes. I guess first, if you would be able to send us a summary of the inclusion-exclusion criteria, just so we make sure that we're getting patients to you. Also, for other trials that you guys are doing, at least me on the cognitive side of things, I feel like I don't always know what other people in neurosurgery are doing. So having a collection of inclusion-exclusions means that I can get everyone to where they need to go.
Sure, happy to do that.
Awesome.
All right.
And then just thinking about the trial, so I guess my first, concern when I heard some of the inclusion exclusion that you have, and I appreciate that you didn't design the trial, but I'm thinking, well, MoCA is maybe not always the test we think about for MPH, right? We think about processing speed a lot more than a general cognitive screening test. So hopefully there are going to be either secondary outcomes, or that won't be the one of the big things that might trip you up. And also a MoCA of 12, we often think about people with MPH and whether or not I should send, and people with anything more than a mild dementia syndrome, I usually don't. But a MoCA of 12, I would think, well, that person's probably not going to respond or be able to really cooperate with a trial or your protocol. So I guess those are my first two
Yeah,
thoughts.
no, exactly. I think, in general, I would argue that, you're probably wanting, most patients with a MoCA below 20 probably don't have NPH anyway, and are having some other dementia type problem. But, and that may be borne out in other parts of the screening process, whether it's the imaging or the response to CSF drainage. I think that's the big thing, right? To me, what makes an NPH patient is they get better after a trial, and dementia patient wouldn't.
And then, so that's going to be the other part is, so there are a whole bunch of MRI predictors, imaging predictors, and clinical predictors of response to shunt, trying to look at that ahead of time. And so some people are looking at, as opposed to callosal angle, because of the differences between measurements, and if you get the wrong angle, so looking at more of a dash, the dilated, disproportionately large subarachnoid space hydrocephalus. So things like, looking at your lateral fissures and making sure those are really dilated, or if you have crowding at the sulcus. So are you guys, do you know if the trial is going to be looking post hoc at features to see who may or may not be responsive to these interventions, and then trying to use that to optimize patient selection in the future?
Yeah, no, it's a great question. And I think that, the answer is absolutely. This is a singular opportunity to get prospective randomized data on not just E-shunt patients, but also VP shunt patients, which we don't have a lot of anyway, and be able to use that information to post hoc to better understand the disease state and which patients are more likely to benefit is going to be, I think, to come as part of the, publications that would come out of this kind of trial. Because I know there are interest in all the investigators to once we have all this data, to be able to use it to help better understand the patients we serve.
Wonderful. And then I guess the last part is this non-inferiority in terms of the TUG test? Because I can imagine if you have equal outcomes, but you don't have to cut into people's heads, you end up having lower chance of side effects.
Exactly.
That would be very valuable, even if you don't have superiority.
Yes, it's I think it is designed for non-inferiority. Yes.
Thanks.
Dr. Weiss?
So thank you. And also, I really appreciated seeing the cases. As someone who knew about the study, but what I wasn't clear about, are you recruiting individuals who are Spanish speaking also?
Yes, yes. Okay. So we have Spanish consent, all are reapproved. So yes, we are.
And so just to a couple of things to piggyback off what Dr. Cohen said. So I don't think a MoCA of 12 is too low. It depends on the person's premorbid abilities and their education, because we know in primary care, our average MoCAs are 16 to 18 in older adults with cognitive concerns without dementia. So I'm less worried about that. I think I was surprised to see that your baseline and your 90-day follow-up MoCA was the same version of the MoCA. And so I would be really worried about practice effect, that they're seeing especially in individuals who don't have Alzheimer's and who don't have primary memory impairment, that they're getting the exact same test. So of course they should be doing better. And if they're not, then, then I'm worried about this not being NPH at all.
Yeah.
They're actually not doing the MoCA in the next trial.
Okay. Thank you.
They're not. They dropped that.
what are they doing instead? That was really what I was, so I'm a neuropsychologist, so I really care. One, I care about the cognitive piece, but also that a MoCA to me wouldn't be sensitive for NPH versus other processes.
Yeah, hi, Amanda Baker, one of the NIRs. So they're doing MoCA into pre-procedurally, but they're not doing the post-MoCA anymore.
Yeah.
So they're only doing the tug after the
Yeah.
procedure.
Okay.
Yeah, it's just to screen out for dementia, really.
Okay.
That's all. Help screen out for dementia.
Well, we have
And
made
then-
a robust effort at the center to really streamline a pathway with champions like Dr. Cohen and Dr. Weiss and Dr. Pariar, and trying to increase referral sources towards neurosurgery and the identification of patients with NPH, with Dr. Weiss structuring protocols for NPH specifically as well, and tailoring her neuropsychological exams. So we're trying to do diligence and hoping that blood-based biomarkers, people won't come in with their blood-based biomarker that's positive from primary care when they have NPH-like looking picture. So hopefully you won't have both kind of confusing things, but we've definitely made a robust effort to try to recognize these patients and provide opportunities for minimally invasive approach for improvement in their clinical care.
Awesome. That's great to hear. And yeah, I did see, so Dr. Baker is a partner in crime here. She's going to be a co-PI, and it'll be either me or her that are doing the E-shunt procedure. And as far as patients randomized to open surgery, my other partner, Dr. Khatri and Dr. Heron-Holly, are going to be doing the surgeries. So it's going to be a big group. It's all part of our neurovascular team that's in this trial and overseeing it.
We do have Dr. Malik on the phone with on the video with geriatrics, and geriatrics does a lot of, the get up and go test, really screening and looking for details in geriatric syndromes for cognitive impairment. So I just, wanted to point out they're doing a lot of this. So it's nice to bring this in as a way to kind of identify folks and be able to provide additional alternative pathways.
Yeah. And it's very exciting. It's minimally invasive, and from at least my initial experience, it's very safe. So it's exciting time for these patients, and hopefully you can find some. I will say that that in the pilot study, because there were fewer sites, we were actually attracting a lot of patients from out of our community to come and get it done. And I hope in the pivotal study that we get a better representation of the patients that we actually take care of in the Bronx.
And Dave, it's nice to see that you had someone with a lot of vascular risk factors, which may be, as Eric
It's
and
normal.
I were nodding before, the vascular risk factors may be causing some of the other cognitive impairment, but you were able to do it in someone with a high risk, and that was really interesting.
Yeah. I mean, what we've learned is that, both, so the compassionate use case and that patient who had a lot of risk factors, both needed AC for different reasons, and we're able to get them on AC one day after treatment, which was pretty cool. It's not something you can do with, open surgery.
Right. Yeah, we love that, and Jude, as you know, is on this call, and it's been a great addition to our center. So for follow-ups and knowing about inclusion criteria, this would be great to share.
Yeah, so yeah, I'm happy to share all the criteria, and I can send it your way, and maybe you can disperse it.
Yes, and the videos were very informative. Dr. Malik pointed that out in the chat. Videos were very helpful, and knowing and screening for geriatric syndromes and gait difficulty, and having a video with an outcome with an intervention, it was really drives that point home. But again, I wanted to thank you for taking the time on a Wednesday night to share and impart your expertise and really appreciate it. And I want to thank everybody for joining. For those of you who don't have the chat available, the code is 61OHED. For anyone not linked to EADS, you can go to eads.com, enter the code 61OHED, follow the instructions, and there's 2 CME credits available.
Before we go,
Doc-
Dr. Malik did put
Yeah, I
a,
see a question from Dr. Malik. So, so do the shunts have to be exchanged? So the shunts can be retrieved. I don't think anyone has ever put in a second one. If there is a failure, they just go to surgery. At least at the moment. That could change once the device gets FDA approved, and then you can use clinical judgment. There is no upper age limit, I think, for the trial, from what I understand.
The question I want to ask Dr. Ashold, how often they get adjusted?
So the nice thing is, the coolest thing about this is they don't have a valve, right?
Oh,
So
okay.
like they don't need to be adjusted. And, you know, so a lot of the main, you know, the surgeons there ask, well, how do you prevent over drainage then? And so the cool thing about the design is that it's a very, very short segment. So the issue with VP shunts is that they're long. They go from the head all the way to the abdominal cavity, and that creates a siphon effect, right? Where you have actually, you know, gravity actually, you know, increases the amount of flow, and you have to be able to kind of limit that. Because this device is so short, you don't have that same kind of siphon effect that you have from VP shunts. And so, so far in all of the NP, of all the patients enrolled, there have been 0% over drainage cases. And so should it ever come to that, you know, the treatment would be to retrieve the device endovascularly and remove it.
Oh, actually, has that anchoring method been used before, separate from the tubing shunt device? Is the anchoring also new?
Yeah, no, this whole technique is a new thing that we don't do in endovascular previously. Now we deploy stents in the veins and the arteries, but for other reasons, you know, either in doing stroke cases or stent-assisted coiling or stenting for tinnitus or idiopathic intracranial hypertension. But those are different kinds of stents, and it's not on a rail with a needle to help puncture the veins. So this is a totally new a technique that we have to learn as neurointerventionalists because we don't do anything like it.
Because I could also imagine you had a very short thing on, you know, oncologic care or other things, you know, not turning around, but essentially turning around once you have that kind of access, being able to, you know,
Exactly.
access your CSF space without, you know, without a shunt, without, you know,
Exactly. So yeah, you're absolutely right. Where this company is going, and probably the next stages would be to use this as a conduit and access to the CSF space. So think of it as a port, right? So probably
out the Ommaya.
Yeah, right. So this can be an endovascular Ommaya. And then that, you know, that'll probably the next kind of innovation after this. But yeah, you're thinking the same way as the company is, for sure.
I just had one last question about the mental health exclusion criteria, because having a comorbid mental health diagnosis is pretty common. I'm the psychiatrist in the group, so I'm a little concerned. I just, when you sent us the exclusion, actually said including like major depression. People could have big
No, depression is okay. Major depression is okay. That's not an exclusion criteria, but schizophrenia or anything that would dramatically impact the ability to follow up, really. I think that's the issue.
But if they had bipolar disorder and they were stable for 20 years.
I think, yeah, that's okay.
Okay.
Yeah, right? It's really if it's an active problem where it would, you know, dramatically impact the ability for a patient to adhere to the kind of the trial design.
Dr. Baker, you may not have met everybody, just really briefly. Jessica Zwirling, I'm the head of the Center of Excellence for Alzheimer's Disease. Dr. Saeed is the Director of Geriatric Psychiatry, as well as the fellowship program. Dr. Weiss is the Director of Neuropsychology and the Division Head for Neuropsychology. Jude Offord, I'm not sure if you crossed paths already, is our nurse practitioner at the center. Dr. Malik is the fellowship director and the director of geriatrics. We're a multidisciplinary team. Dr. Cohen is the director for site education at the center. And there's some other people on the call. Dr. Diana Bronson is our resident neuropsychologist. Michael Tao is dual boarded at Taxter Road in psychiatry and neurology. John McGinley, you probably know from the OR as well, is our specialist in neuropsychology as well. And the rest of the team, Dr. Steve Matthews is our project director. Just wanted to briefly introduce, we don't often get to see people on camera at 5:20 at night on a Wednesday. So I just wanted to make sure I addressed everybody.
Oh, thank you so much. Nice to meet everyone. And I'm one of the neuroradiologists, so if there's also a question on any of the imaging for this, like, please reach out. Let me know.
So we'll bug Judah less. Thank you.
And
Sounds good.
at some point in the future, I know there's a lot of updates in neuroimaging for MPH. That's something I know I want to learn about. So if we can rope you into a future talk on that, that would be really cool too.
Yeah, sure, absolutely.
All right. Thank you so much again, dude.
Yeah, no, great. You know, it's rare that we get the opportunity to kind of mingle. So thanks for everyone to taking the time to listen, and hopefully we get to talk more, help treat these patients better.
Thank you so much. Have a good night, everybody.
Bye.
Good night.